Assalamu alaikum, friend. I want to present the greetings to all of you. If you are listening this video in the morning, so good morning. If you are listening this video in the evening, so good evening. My friends, actually, I want to present in front of you one case which is very important, and I will try to explain you first of all the patient and then the suffering of the patient. First of all, I wanted to tell you the detail of the patient and later the suffering of the patient, such as the problem which he was suffering in that. My friends, actually, my topic is actually the hangman fracture, and you are listening Dr. Muhammad Qazafi views, and my name is Dr. Muhammad Qazafi. I am a consultant neurosurgeon working since 18 years as a consultant neurosurgeon in different parts of the world. And now I want to present the real case which I have encountered multiple times, but I wanted to take as an example, and I will take as an analogy of this patient, and then it will be presented to you. The topic is the hangman's fracture. It seems to be very simple, but I want to explain it in detail, and somebody would like to understand this thing in detail. I hope and this video will be helpful for him. I have a 28-year-old male presented after a high-speed motorcycle accident, and he complained of the pain in his neck but denied numbness, tingling, or weakness. Past medical history was unremarkable, or we can say non-significant. On examination, all four limbs, upper limbs and the lower limbs, power 5/5 with full strength, bilateral upper extremities and the lower extremities, sensation intact to light touch throughout, and the tenderness to palpation of the posterior occipital spine with no obvious area, but definitely in the lower occipital area and the upper cervical area was more palpating, more specific area for the painful palpation. For the differential diagnosis, definitely in that area, as I mentioned you, with the accident and with the palpation tenderness or the movement tenderness, specifically in the lower occipital area and the upper cervical area, then definitely you would understand that it could be the hangman's fracture. And my topic is hangman's fracture. Other differential can be possible, and it should be in your mind, such as some neoplastic infiltration or chordoma, but in this age very uncommon, but you may consider these things also. Osteomyelitis, tuberculous osteomyelitis in different parts of the world is still there, specifically in my country, Pakistan. And in India, and in Afghanistan, and in some African countries where the TB is common, and specifically the HIV positive patient have tuberculosis. So we cannot deny this thing. Simultaneously, degenerative changes also possible. In the Gulf area, you cannot deny the brucellosis, even though it's a very good hygiene condition in the Gulf area. So osteoporosis, and you cannot deny with that. So these should be included in your differential diagnosis. We did all other imaging such as I want to describe you here. The image such as the traumatic, when we are suspecting the traumatic hangman fracture, you know that there is we find that the C2 pedicle and the left C2 pars interarticularis with STIR signal apparent on MRI and indicating significant soft tissue injury in the setting of trauma, and there is a little differential diagnosis to consider. Concomitant vertebral artery injury could be ruled out with the CT angiogram. So CT angiogram, we have to check when we are considering the hangman fracture, and when we are talking about the classification and the grading of the hangman fracture, then definitely you realize this disease has multiple shapes and effects over the body, and we have to treat in a different way. Here I want to I want to warn you that we have to exclude the vertebral artery injury, and we should do the computerized tomographic angiogram for confirming that there is no vascular injury such as the vertebral artery injury. Other workup we have to do, and we did for this patient. And in this patient, I want to mention you, he has no vertebral artery injury. Then laboratory investigation you have to do, such as the routine labs investigation. If you have to plan for surgery also, then you have everything in your hands, then you can take a decision fast. MRI of the cervical spine, when we did, we found there the ligamentous injury, and CT imaging, what we did, we found there the bony injury, such as I mentioned you, C2 pedicle injury and on the right side, and the left pars interarticularis injury, it means the bilateral injury with him, and CT or MRI angiogram, as I mentioned you, we did to exclude there is any vascular injury, and as I mentioned earlier, there was no vascular injury. Flexion and extension, plain film, and we did to check which kind of the classification, because the classification is very important here, because according to the classification, and you are planning to treat the patient according to the classification and the grading of the fracture. The pathophysiology I want to discuss here in detail, because before I discuss with you the patient as an analogy, it is a real-time patient, but I took here as for the analogy of this patient. But now for this disease, hangman fracture, but now I will present the pathophysiology of the hangman fracture, and then I will discuss with you the classification of the hangman fracture. You know that unlike many of the other cervical vertebrae, the axis has a unique anatomic morphology. In order to understand a hangman fracture, it is important to better define two bony fractures of the C2 vertebra, the pars interarticularis and C2 pedicle. In our case, they are the right-sided pedicle fracture and the left-sided and pars interarticular. So that's why I chose the proper patient for you people, so you can understand and understand the proper hangman fracture. It is important to better define two bony features of the C2 vertebra, the pars articularis and the C2 pedicle. These two terms are often used interchangeably, but are in fact distinct bony elements. They are two different bony elements, but we are using concomitantly. And C2 pars interarticularis is the bone that lies posterior to the transverse foramen. So extending from the superior articulating surface of C2 to the inferior articulating surface of C2. So it is, you know that what I try to tell you, these two terms are often used interchangeably, but are in fact the distinct bony element, and the C2 pars interarticularis articulating surface of C2 to the inferior articulating surface of C2. So the pedicle of C2 are bony structure that lie medial to the transverse foramen and immediately underneath the C1 and C2 facet joint. They are located and angulated much more medially compared with the pars interarticularis. So the hangman fracture is better classified as a bilateral fracture extending through the pars interarticularis and a pedicle of the axis. So the most fractures of this type are secondary to the hyperextensive force in combination with axial load, and for example hitting your face on the windshield during the high-speed motor vehicle accident. However, these feature pattern can also be seen under condition of flexion and distraction also, but the most common, as I mentioned you with the example, that the hyperextension with the axial loading. In the same manner, there are different grading systems used to classify these fractures and are based on the orientation, degree of the angulation and the displacement of the fracture. Here two things you have to understand. One is the degree of angulation and degree of distraction or extent of distraction. So in that manner, in the Affandi system, first of all, I will tell you Affandi system and then I will tell you other modified system. Now I am starting the classification, which is also the part of the pathophysiology. So as I mentioned you, the Affandi system, the type 1 fracture is a hairline fracture extending through the pars pedicle without significant angulation or displacement. So we consider this is the only fracture, hairline fracture, no angulation, no distraction, type 1 fracture of the Affandi system. Affandi 2 is telling there is a significant displacement of the C2 body relative to the C3 body, or we can say anterolisthesis. So we consider Affandi 2 means anterolisthesis of the C2 over the C3, we consider this is the Affandi 2. In the same manner, Affandi 3 fracture is similar to the type 2 fracture, but except the body of the C2 rests in a flat position and making some kyphotic position. So this angulation, considered this angulated position, considered this is the type 3. So it has the three main types of Affandi system. But Affandi has been modified by the Levine system and Levine and Edwards system. This is a combined system. So it is commonly pronounced with the Levine system, Levine, Levine and Edwards system, which is proposed adding a type 2A which has no displacement but severe angulation of C2 body. I want to discuss with you Levine system a little in detail, and then I will discuss with you later the Francis system also. So the hangman fracture rarely cause the few things you have to understand. Few things, it is a pointers. 1 point. Hangman fracture rarely cause neurological injury because of the consequence or of the canal at this level. Lot of canal, no problem. No neurological deficit usually you will find, very rare, but may be considered biomechanically unstable in certain cases. Yes, it can be. Neurological injury may occur as a result of vertebral artery injury. Any associated posterior circulation abnormality seen in patient history or physical examination should raise suspicion for dissection of the vertebral artery. So as I mentioned you before, that Affandi system has been modified by the Levine and Edwards system, and the system of the Affandi et al. Modified by the Levine and the Edwards system, and is widely used for the grading of the adult hangman fractures, but not applicable over the pediatric age group. You have to remember this. The Levine system is not affected or not apply over the pediatric age group. So the angulation is measured as the is the angle between the inferior end plate of the C2 and the C3. So C2, C3 angulation or the body angulation is considered here prime for us as a reference when we are talking about more than 11 degree or less than 11 degree. So you understand this thing. And anterior subluxation of C2 and C3, when we are talking about the subluxation, means distraction over the C2, C3 vertebral body, it considered here more than 3 millimeter or less than 3 millimeter. When I am talking about the more than 3 millimeter or I am talking about the less than 3 millimeter, you have to understand here C2, C3 subluxation. Okay, and this is called is a type 2 according to the Affandi system. And as you know that it is a surrogate marker for C2, C3 disc disruption, or we can say the disc prolapse or burst, which can be evaluated more directly with cervical spine. So the grading systems we are presenting in front of you now with the Levine system, and it is like that. I will tell you, I will start the Levine system like that. The type 1, I am talking about the type 1. Type 1 telling there is a vertical pars fracture just posterior to the vertebral body. Vertebral pars fracture just posterior to the vertebral body. But on radiology you will find there is a less than 3 millimeter subluxation of C2 over C3. It means less than 3 and no angulation. And the mechanism of injury is loading and extension, so which is the principal mechanism of action, and these fractures are considered the stable on the flexion and extension in X-rays, and neurological deficit is very rare. So this is the detail of type 1. In type 2 fracture, in type 1A, now I am talking about the Levine, Levine for grading up. Grade up means A1. A1 is telling us the fracture line on each side are not parallel. Fracture may pass through the foramen transversum on one side, or other one is a different side. So this fracture line, when you see on the radiology, this fracture line may not be visible on the X-ray. So the anterior C2 vertebral body may be subluxed more than 2 to 3 millimeter anteriorly on the C3 vertebral body, and the C2 vertebral body may appear elongated. So the mechanism of action here, or mechanism of injury, is hyperextension same, and lateral bending we are adding in axial loading with lateral bending. It is called mechanism of injury for the type A1 for Levine, which is little different from the Affandi. And this is the atypical kind of the hangman's fracture, and spinal canal may be narrowed, but 33%, not more than this usually. So here again the neurological deficit is not very common, rare. Still the neurological incidents are less or not very common, we can consider here. Again, now I am grading up one more grade, such as grade 2 for the Levine system, and here I just want to the vertical fracture through pars disruption of C2 C3 days and posterior longitudinal ligament. So the mechanism also, on the radiographic finding, we find there is a subluxation of C2 on the C3, which is more than 3 millimeters, and our angulation with angulation slight anteriorly compresses of the C3 level. So here the axial loading and extension with the rebound flexion is maybe the mechanism of injury, and it may lead to early instability. Neurological deficit again very rare and usually reduced with the traction. You apply traction and it can be reduced. I want to grade up. Grade up means 2A, like 1, then 1A, then 2, now 2A. Now I am talking about 2A. 2A is oblique fracture, usually antero-inferior to the posterior posterior superior, and this mechanism of injury is flexion, distraction, posterior arch falls in tension, and these we can consider these are usually very rare, but these are stable. The traction we cannot apply here because the traction may increase the angulation and widening of the disc space, so do not apply the traction here. But when the treatment will come, I will talk to you in detail for this thing. Again, this little subluxation in the same 2A I am talking about, this is usually less than 3 millimeter, but the angulation is more than 15 degrees. Again, I want to mention here, such as the Levine fractures last grade, I want to tell, which is called the 3. This 3 is like that. All the things of the type 2, I mean the vertical fracture through pars disruption of the C2, C3 disc and posterior longitudinal ligament, it will happen same like the type 2, but additionally bilaterally C2, C3 facet capsular disruption. It means all columns has been disrupted here, and the C2 posterior arch free floating and the anterior longitudinal ligament may be disrupted or stripped off from the C3 spinous process. In that manner, when you see the radiology, the facet of the C2 and C3 may be subluxed or locked. So the mechanism of injury considered here, that this is the capsular disruption followed by the compression with hyperflexion, or we can say axial loading. This kind of the fractures are usually not very common, are rare, these kind of fractures, but if it is like that, then a neurological deficit may occur, and maybe we can say the fetal, or we can say the fatal and dangerous facet dislocation, and usually cannot be reduced by the for example, close reduction. Traction should not be applied here because traction can be a dangerous here, specifically in that case. As I mentioned, when the Affandi system is a primitive system for the Levine, and Levine is a modified system of the Affandi system. But here one more very good and we can say important system, which is very simpler than all other system. For me, I found this, which is called the Francis system, and I want to present the Francis system in front of you, which is also the classification of the Francis grading system for the hangman's fracture. Here they are telling us 5, but I hope it is very easy to understand and easy for application for the patient. Just I want to present you like that. They are presented into the 5 grades, and they are depending only upon 2 things. One is the angulation and other is the displacement. Angulation and displacement. Now I want to present grade 1. Grade 1 is telling if less than angulation, means less than 11 degree angulation and less than 3.5 millimeter displacement, you are considering grade 1. When you are going to grade 2, it should be the degree of angulation more than 11, but the distraction should not be more than, or you can say consider should be less than 3.5 millimeter. It is called grade 2. Again, now I am telling the grade 3. Grade 3 is telling, yes, this is a total opposite of the grade 2, like here is the angulation should be less than 11 degree, but the distraction will be more than 3.5 millimeters. In the same manner, the 4th grade will consider in that situation both angulation and distraction will be increased, such as angulation will be more than 11 degrees and the distraction will be more than 3.5 millimeters. And in the same manner, the 5th grade will tell us about the disc disruption and associated with the capsular disruption. So I want to tell you here simply, if you are matching this Francis system with the Levine system, so the Levine type 1 like a Francis grade 1 and the Levine type 3 like a Francis grade 4. Here I just want to present you a few facts in front of you, such as most 95% are patient, 95%. Now classification is finished. I'm talking about little more about this fracture, and few facts I want to discuss with you. It will helpful for you to understand and to remember. 95% or more than 95% patients of the Hangman fractures are neurologically intact, and those few with the deficit are usually minor paresthesia or monoparesis, and many recover within 1 month. Almost all patients are conscious and will have cervical pain, usually in the upper posterior cervical region. As I mentioned, my patient, which I consider for the analogy for this Hangman fracture, he has the same problems like that. In the same manner, the occipital neuralgia is not uncommon, and there is a high incidence of associated head injury, and there will be other associated C-spine injuries such as C1 fracture or Clay-Shuvler fracture. So in 1/3, the most occurring in the upper 3 cervical level, which is 1/3 patient may suffer with the C1, C2 and C3 all fracture combined. So these are usually the external sign of the injury to the face and head associated with the hyperextending and axial force, which I mentioned earlier. And for evaluation, as I mentioned in my patient, people are doing the same manner. The cervical CT with the sagittal and coronal reconstruction should be done, fully axis the fracture, and the CTA should be done to evaluate the vertebral artery if the fracture extends through the foramen transversum when you consider this, especially in the Levine type A, which is very rare, but it could be, so we have to exclude with the help of CTA. And in patient with the symptoms suggestive of the stroke, so the recommended CTA for the C2 fracture, especially for the CTA angiography. MRA also telling us lot of things, but in combination with CTA, it is more informative. In the same manner, the MRI, cervical MRI, should be done to look for the C2, C3 disc disruption, a marker of the instability in these kind of the problem, such as Levine grade 2, which usually require the surgical stabilization. Whenever the traumatic disruption happen of the C2, C3, you should go for the surgical stabilization, and finding may include the abnormal increased signal intensity on MRI, so the best seen on the sagittal FLAIR image on T2 weighted image. X-ray has a very important role. I just want to discuss for X-ray for you, so you can understand how X-ray can be helpful in our situation. Sir, first of all, I want to tell you few things about the X-ray here, so you can understand. X-ray, lateral C-spine X-ray shows the fracture in the 95% of cases. Also demonstrate C2 angulation and subluxation both. Most fracture pass through the pars or the transverse foramen, and 7% goes through the body of C2. Instability can usually be identified as a marked anterior displacement of C2 on C3. So guidelines such as the unstable if displacement exceed 50% of the AP diameter of the C3 vertebral body. So the excessive angulation of the C2 and C3 considered here unstable, or maybe excessive motion on the flexion extension film also considered there is unstable. So the patient suspected of having Levine type 1 fracture are neurologically intact, but should have physician supervised flexion extension X-rays on to rule out, or you may consider this is a reduced kind of type 2 fracture. So these all are things which we are discussing. Usually we are discussing surgical options later, and we can say the conservative prior to surgical. But right now I want to discuss with you surgical option first, and then I will discuss with you the conservative treatment of these kind of hangman fracture patient. As in the surgical management is indicated for those with significant angulation and displacement, or neurological deficit, or a disruption of the bilateral capsule, or the disruption of the C2, C3 vertebral disc. So we have here two options. One is anterior approach and second is the posterior approach. I want to discuss with you thoroughly for both kind of the treatments here somehow, so you can understand. Such as the surgical technique for an anterior C2, C3 discectomy, the patient is positioned supine and intraoperative fluoroscope is used to ensure good alignment before skin incision, and intraoperative neuromonitoring may also be used. A combination of the blunt and sharp dissection is carried down to the prevertebral fascia. In the same manner, a localizing image is taken to ensure the appropriate level is exposed. A discectomy is then performed. An interbody device, autograft or a allograft, or then placed in the disc space. So depending on the type of the interbody device used, a plate may be secured to the C2 and C3 bodies to prevent graft extrusion and aid in fusion. So 2 screws in C2 and 2 screws in C3, which is explaining the anterior approach. As you know, anterior C2, C3 discectomy with fusion optional, and the anterior plating or zero profile graft or plate performed via transverse anterior cervical incision midway between the angle of the jaw and the thyroid cartilage. So few people are using oblique incision instead of the transverse incision. Preserve more motion by excluding C1. So this approach is also recommended for established non-union and not optimal for Levine type 3, requiring open reduction and internal fixation for locked facet. Also used when at least a partial reduction cannot be achieved. And technique for special consideration for approach to the C2 C3 junction. See the we can see here the different technique apart from that. Now I want to discuss here with you some fusion technique through the posterior approach. If the fracture is not transfixed or osteosynthesis, such as I want to present you what is osteosynthesis. When a C1 C2 fusion is required, this depends on the integrity of the C2 C3 disc and facet joint capsule. So otherwise a C1 and C3 fusion could be done, or it is also an option. Occasionally the occiput is incorporated as well sometime, but not most of the time. Options for C1-C2 fusion and C1-C2 wiring and fusion, C1-C2 lateral mass screws or rods can be considered. Osteosynthesis, as I mentioned, this is the screw placement from the posterior approach through the C2 pedicle across the fracture fragment, and reduction must be achieved before the screw holes are drilled. And the technique for the C2 pedicle screw we use as we are considered in other cases. So the posterior fracture fragment may be over drilled with the 3.5 millimeter drill, and the tap head is placed on the hole and use a 2.7 millimeter drill to drill the vertebral body, and the screw length should be 35 to 40 must be in the average adult. Alternatively, a leg screw may be used with the 20 millimeter which is untethered. But here, for the posterior point of view technique, I want to discuss with you a little more. For the posterior instrumentation fusion, the patient is placed in a Mayfield head holder and turned prone in the chest roll. The patient is placed in a slight reverse turned lumbar position with the knee flexed, and before skin incision, lateral fluoroscope is used to ensure oblique alignment, and C3 posterior element are then exposed with very well. But here I want to tell you the incision is centered from the inferior occipital bone to the C3 spinous process. The C1, C2 and C3 posterior element are then exposed with electrocautery. If screw placement is planned, the medial portion of C1 lateral mass are exposed and palpated with a number 4 pen field. So with that pen field you can dissection perform on this area. The C2 nerve root should be mobilized inferiorly, or alternatively may be sacrificed during the placement of the C1 lateral mass screw. But judicious use of the fluoroscope should be used during the placement of the C1 screw especially. C2 screw may be placed in the pedicle via pars interarticularis, which is mentioned multiple times. Frequently the C2 level is skipped entirely, and the C2 translaminar screw may be alternatively be placed. So the lateral mass screw are placed at the C3 level. If placement of the screw is contraindicated or not feasible in that circumstances, then sublaminar wiring technique may be used regardless the cortical bone overlying the C1, C2, C3 region is decorticated. Autograft and the allograft are placed over the decorticated segment to achieve bony fusion. So the posterior fusion may also require decompressive laminectomy in patient with the neurological injury. Complication avoidance and management is very important. You know that the CT imaging is a crucial before instrument to assess the location of the vertebral arteries, but the combined anterior and posterior approach may provide the additional stability on cases of the significant displacement and angulation. Imaging of the entire cervical spine, include the cervicothoracic junction, should be obtained given the relatively high frequency of adjacent bony injury, so you can avoid any kind of further injury. Here I want to discuss with you a little about the conservative management. Here I want to discuss with you where the traction we cannot apply or we should not apply, because this is a very important for this message. Actually, in Levine type 2A, type 2A, traction will accentuate the deformity, it will increase the deformity traction. So avoid the traction in type 2A Levine. Fracture should be reduced by immediate placement in hollow west, bypassing the traction. Do not do traction, and with extension and compression apply with the help of hollow west, and immobilization apply with the help of the hollow west for at least for 3 months. And the union rate with the hollow west, especially in type 2 Levine, it is very good, 95% very good. So you should not operate if the conditions are like that. If these conditions are like that, you should operate. For example, inability to reduce the fracture or include most Levine type 3 or some type 2, okay, you operate, but otherwise should not operate. Failure of the external immobilization to prevent movement or fracture site, then you have to operate, because you are failure, you cannot do it. Then you operate. Traumatic C2, C3, disc herniation with compromise of the spinal cord, then you have to operate, because you cannot treat with conservatively. Stabilization non-union, for example, evidence of the movement and flexion extension. So in that case also you should operate. You cannot do with for example, for more simple thing, if according to classification Levine type 2 and type 3, you should operate. Francis grading type 2, type 4 and type 5, you operate. Or either anterior displacement of C2 vertebral body over the C3 vertebral body near or equal or little more than 50%, then you have to operate. Or if angulation produce widening of either anterior or posterior border of the C2, C3 disc space, and the height of the normal height considered very abnormal, then you have to operate. Otherwise you can avoid. Now one more thing, as I mentioned you, traction you should not apply where? One, I told you that type 2A should not apply. Likewise type 3 you should not apply the traction, because it is dangerous with the locked facet. So the open reduction and internal fixation is recommended. Prior MRI before the surgery is recommended. C2, C3. So what I want to tell you here, the stable fracture such as the Levine type 1 or Levine type 1A, so or the Francis grade 1 or grade 3, these all considered are the stable fracture, and these kind of the fracture should be treated with the help of the hard collar for at least for the 8 to 12 weeks, and it is considered very well. But the some fracture, if no neurological deficit, and such as type 2 fracture, and even though and they have less than 5 millimeter subluxation, and so then you try with the help of the hard collar, and 95% they are responding, but in 5% casing it is non-union happen or not responding, then definitely you may consider the surgical option, which I told you earlier. And I hope I can convey my message humbly to you. This one liner I want to tell you, this hangman fracture is different from that conventional judicial hanging done and by the court of law and for the penalty of the death. That one is a hyperextension, but not axial loading, but distraction. So it is little difference. It is a difference between the judicial hangman fracture and the hangman fracture because of the motor vehicle accident. So for my patient, we did the surgery and we did the posterior fixation. I performed that surgery because I'm basically a spinal surgeon. Then I did the posterior fusion and anterior. I did both for him, because the angulation was more than 50 degrees. So I apply first of all anterior plate because the facet joint also the locked. I did not apply the traction. And then in the same setting, I turned the patient in a prone position, and the procedure as I presented in front of you, I did the 2 screws. I placed lateral mass screws, one in the C1 and other I did not use the C2. I used the C3 because I am very convenient with the C3, because the lateral mass of the C3 is easy to do as compared to the pars interarticularis of C2. So thank you very much for bearing me, listening me. I hope I try to make more informative videos for you people, and appreciate us, share us, and like us, subscribe us. Thank you so much.